Good evening, everybody. Welcome to the clinical grand rounds. For today's CGR, the Department of Neurosurgery, in collaboration with departments of endocrinology, neuroradiology, and neuropathology, is going to present the multidisciplinary management of Cushing's disease. To introduce the topic and give an outline of the presentation, I would like to invite Professor Ashish Suri.
Well, good afternoon. Welcome to the CGR, which is a multidisciplinary CGR actually of Cushing's disease. And just to thank all my, actually a neuroendocrine collaboration that we have. Normally, most of our collaborations are within the center, but this is actually a very strong collaboration that we have uh, with Department of Endocrinology. So it has neurosurgery, endocrinology, neuropathology, neurology, neuroanesthesia, and many others who actually contribute. And we have to understand that Cushing's disease is actually a hypercortisolemia because of the ACTH adenomas in the pituitary gland and the so-called pituitary adenomas. And we have to actually, there's a difference between Cushing syndrome, which is actually a syndrome because of cortisol excess, which can be because of pituitary, adrenal, even exogenous, and it can be because of iatrogenic because of medications, and difference from Cushing's disease. So I would like to invite our endocrinology, Dr. Setu, under guidance of Dr. Rajesh Kargawat, will be presenting the clinical and the biomechanical features.
Thank you, sir. So I'll be presenting the clinical and biochemical features of Cushing disease and how we as a Department of Endocrinology ensure that the diagnosis is Cushing disease and not something else before we subject the patient and refer them to neurosurgery. So first reiterating the definition of Cushing syndrome, which is defined as a constellation of signs and symptoms associated with prolonged exposure to inappropriately elevated levels of plasma glucocorticoids. And this Cushing syndrome or this exogenous, glucocorticoid excess can be both endogenous or exogenous, depending whether it's taken from outside or produced inside. And if it is endogenous, then it can be ACTH dependent or independent. I would like to take you towards this the diagram that we have just to show that the hypothalamic pituitary adrenal axis that we have and how we utilize the positive and the negative feedbacks while evaluating a patient of hypercortisolism. So from the hypothalamus, there is a positive feedback by CRH, which acts on the anterior pituitary, which forces it to release ACTH, which acts on the adrenal cortex, from which glucocorticoids are released, which act on end organs to produce the signs and symptoms which occur during the axis, as there is a negative feedback which occurs way back at the hypothalamus as well as the anterior pituitary. Normally, in a physiological state, there is a very strong both positive and a negative feedback, which ensures that there is a circadian rhythm of the cortisol as well as a normal physiological level of cortisol. Just a quick brief on the etiological classification of Cushing syndrome. So we have an exogenous cause, which can be iatrogenic or which can be due to non-iatrogenic causes like bodybuilding, etc. And then we have endogenous causes, which can be ACTH dependent or ACTH independent. ACTH independent are because of autonomous secretion from the adrenal in the form of either adenoma, carcinoma, or hyperplasia. And ACTH dependent can be because of excess release from the hypothalamus in the form of increased CRH production, or from pituitary lesions, which is the Cushing disease, which is the topic of our present discussion. And ectopic ACTH causes like small cell or root cell carcinoma of the lung, bronchial carcinoids, pancreatic NETs, etc. And as per the AIIMS experience, which was published in 2014, we had shown that 27 years of experience in which we evaluated 364 patients of endogenous hypercortisolism, out of which we found that 80% had ACTH dependent, of which the predominant was Cushing disease. And we can clearly see in this age-wise graph that from 10 years onwards up till 70 years, Cushing disease predominant is the endogenous hypercortisolism is a cause of endogenous hypercortisolism. So coming on to the signs and symptoms, the symptoms are what we've classically read: having centripetal obesity, body aches and pains, fatigability, muscle weakness, endogen excess in the form of hirsutism, oligomenorrhea or acne, and osteopenia or osteoporosis presenting as fractures on minor trauma, and psychiatric disturbance. While signs can be divided into catabolic signs that are having striae or thin skin or proximal muscle weakness, and then we have anabolic signs as dorsocervical pad of fat or supraclavicular fullness that we see on examination, and then we have metabolic signs like hypertension and diabetes. This is the classical Cushingoid habitus that we usually get as a spotter. And what is classical about this is the findings that the patient would have an obese centripetal obesity with the classical thin limbs. Centripetal obesity would also include having a round face with the plethora and a double chin appearance, along with supraclavicular fullness and thoracodorsal fullness, thoracocervical fullness. Along with that, hyperpigmentation, which we can see on skin folds and skin creases. On skin examination, it would be a very thin skin which can bruise easily, and Cushingoid striae on abdomen and proximal muscle weakness. So classical textbook description says that it's a lemon on matchstick appearance, and you can classically see that the face and the abdomen would be enlarged with the thin skin, with the thin limbs. There would be a dorsocervical pad of fat, which colloquially used to be known as buffalo hump, and rounding of face, which was colloquially known as moon face. And then we would have facial plethora or hyperpigmentation along with supraclavicular fullness, as we can see on the second picture. Excess hair growth in the third picture, and central obesity with classical Cushing striae in the fourth picture. One of the classical stigmata of Cushing syndrome that we see is the Cushing striae, and which are defined as having a purplish or reddish hue on the lower flank, sides, thighs, arms, and the popliteal folds, which are classically more than a centimeter wide and are dehiscent on examination. These need to be differentiated from striae gravidarum, which are not that wide, and they usually have a reddish hue, and striae albicans, which have a whitish hue, and both of these are physiological findings and not to be confused with the classical Cushing striae. So coming on to the workup and the diagnosis, the most important part is that we have to approach the patient in a stepwise manner, and this always is an important part specifically for the Cushing syndrome, because we can get confused a lot during the workup if we are not very sure about the way we are proceeding. So to begin with, we have to do a clinical screening, and we have to look at the discriminatory signs. I'll come to this on the next slide. Then we have to do biochemical screening, and if positive, we have to decide whether the patient has an ACTH dependent hypercortisolism or independent, and further go on to localization of tumor by radiological imaging and then functional imaging if possible. And if we are able to localize, if we can subject the patient to surgery, well and good. If not, then we have to look at the medical therapy or bilateral adenectomy as the end resort management. So first we have to do clinical screening, and what has happened is that with the rise in prevalence of obesity and metabolic syndrome, the signs like hypertension, diabetes, obesity, they have led to a lot of confusion with possibility that we may end up evaluating these metabolic syndrome patients as Cushing's, and we may end up burning our finger. So the most important part of clinical screening is that we have to look at the discriminatory signs, which are defined as the signs which are very specific for Cushing disease or Cushing syndrome rather. So the discriminatory signs are having facial plethora, proximal myopathy, and the Cushing striae that I have defined, easy bruisability, and a very specific sign in children is that there would be a reduced height percentile despite having adequate weight gain or more than adequate weight gain. And symptoms are what are classical of metabolic syndrome, but then if they occur at a young age, we really have to and should screen for Cushing syndrome. So in the presence of hypertension, diabetes, and osteoporosis, specifically with vertebral fractures coming at a young age, we should do a clinical screening. And rest of the signs that I've defined are less discriminatory, and we usually do not take them into account when we're doing a clinical screening. So if the clinical screening is positive and we are suspecting Cushing syndrome, the first test that we need to do is take an 8 AM basal cortisol and rule out that it is suppressed. If it is suppressed, if it is less than 5 microgram per deciliter, then it is due to an exogenous cause and we have to get back and take a proper history. However, if it is not suppressed, then we move on to the next step, which is the biochemical screening. And in this, we utilize the physiological feedback that occurs in a normal circadian variation of the cortisol. That is, at the night time there is a dip in the cortisol. So if we take 11 p.m. serum cortisol or 11 p.m. salivary cortisol and they are not suppressed, then it means that the patient might have a Cushing syndrome. And if there is no loss of negative feedback by giving dexamethasone either single dose or broken down over 2 days, and if the pituitary axis is not suppressed, then again we suspect that there is a Cushing syndrome. And we look at that increase in the total 24-hour cortisol secretion in the form of 24-hour urinary free cortisol levels. And if either of these tests are abnormal, then it is suggestive of Cushing syndrome. And we label the patient as having Cushing syndrome, and we move on to the next step, which is to localization of tumor. And in this, the first part is whether it is ACTH dependent or independent. And we have a cutoff defined as less than 5 being independent and more than 20 being dependent. If we have indeterminate values between these two, then we do multiple repeats of ACTH, ensuring that the cold chain is maintained because ACTH is a heat labile peptide. And if still not sure, we can go ahead with a CRH stimulation test. If ACTH dependent has been proven, then we do dynamic tests. These tests are done to prove whether the ACTH is a utopic source from the pituitary or from an ectopic source, like from a neuroendocrine tumors. So we utilize the negative feedback path. That is, we do a high dose dexamethasone suppression. We give a higher dose of dexa, and we see if if after 48 hours the cortisol values are suppressed or not. If it is, then it kind of points towards a utopic source. And as a positive stimulation, we give a CRH 100 micrograms, and we evaluate the ACTH and cortisol, and there are fixed criteria how much rise should be present. And along with that, we also do a CA-MRI cellular to have a look at the pituitary. In case of discordance between these tests and MRI does not show a very characteristic pituitary adenoma lesion, then we have what is known as IPSS, or inferior petrosal sinus sampling, with or without CRH stimulation. And in this, we look at the gradient between the central, that is near the pituitary, and as well as in the peripheral blood. And this gradient, if it is high, it proves that the source of ACTH is utopic. And after localization, if we've proven that it is utopic or ectopic, we can further go ahead for a targeted localization imaging. And further imaging of the would be explained by Professor Ajay Garg. So.
Thank you. The MR imaging modality is the imaging modality of choice for the evaluation of Cushing disease. In the imaging protocol, we do thin sections imaging of the sella in the sagittal and coronal plane, followed by pituitary perfusion or dynamic imaging during injection of contrast, and then we do post-guide imaging in sections 2 mm slices. This dynamic pituitary improves the microadenoma detection by 10%. Here we take less than sub-millimeter sections covering the whole of the sella. The temporal elution is around 14 seconds, and we take 12 measurements. The normal pituitary gland is outside the blood-brain barrier, so it shows enhancement. The beginning, the enhancement will be seen in the region of the stalk and this base of the stalk, and then later on, the whole of the pituitary gland show enhancement by 80 seconds. And most of the time, the microadenoma, there is a delay of around 60 to 200 seconds between the enhancement of the gland and the adenoma. So we make use of this fact and do the dynamic imaging and pick up early enhancement of the gland, and the microadenoma appear as non-enhancing structure. The normal in adults, the normal pituitary gland is iso-intense to the white matter on both T1 and T2 weighted images. Posterior pituitary gland appear as hyperintense structures, which is bright on T1 weighted images. The pituitary stalk is in the midline. So as you see, the pituitary gland has got homogeneous signal intensity in the normal patient. In Cushing disease, Cushing accounts for around 10 to 15% of pituitary adenomas. In most of the cases, we see pituitary microadenomas within the pituitary gland. In our experience, up to 20% of the cases, we see pituitary macroadenomas. Sometimes we can see ectopic pituitary adenoma in the region of the nasal cavity, cavernous sinus, sphenoid sinus. Sometimes the corticotroph adenomas, they are clinically silent. And most of these adenomas, they are macroadenomas, and they show invasion of the cavernous sinus. They are large in size. Let's look at one of the example of pituitary macroadenoma. Here the tumor is located in the left side of the gland, bright on T2 weighted images, bright on T1 weighted images. And on contrast, we can see the displacement of the pituitary stalk towards the right side, and the tumor is appearing as non-enhancing structure. Similarly, in this example of pituitary perfusion, we do. Here the tumor is iso-intense on T1 weighted images, appearing as non-enhancing structure on T2. The stalk is deviated. If you look at the enhancement characteristics of the pituitary tumor, the adenomas, they show slow enhancement of the contrast, while the normal pituitary gland, the enhancement curve is quite steep. This way we can differentiate pituitary adenoma from normal pituitary gland. In this example shows the utility of the dynamic enhancement. On plane T2, T1 and contrast, we don't see any non-enhancing structure. But if you do the dynamic scan, on the left side of the paracellular region, we can see this This portion of the soft tissue is showing delayed enhancement. So this is the pituitary macroadenoma, which is not enhancing during delayed scan. But if you look at the normal post-grad scan, the tumor is showing enhancement now. So the dynamic scans help us to differentiate pituitary macroadenomas. This is an example of residual pituitary adenoma in a patient of macroadenoma who was operated. Now the tumor is iso-intense, bright on T2 weighted images, and showing less enhancement compared to the rest of the pituitary gland. Sometimes the pituitary adenomas in Cushing disease also present with hemorrhage. This is example of hemorrhage within the pituitary adenoma, which is bright on T1 weighted images, both in sagittal and coronal images, and the tumor shows peripheral enhancement, which is very well seen on these subtracted images. Really, in around 20% of the cases, pituitary adenoma is macroadenoma in Cushing disease. Here, the tumor is in the sala suprasellar region. These tumors have, along with the secretory activity, they compress the chiasm and present with visual symptoms. The tumor is now in the sala suprasellar region, causing chiasmal compression and extending into the cavernous sinus on the left side and encasing the ICA. Rarely, the pituitary tumors can be ectopic. This example, in our experience, the tumor was located in the root of the stalk, which was iso-intense on T1, bright on T2, with iso-intense on T2, and showing less enhancement compared to the normal pituitary gland. This was confirmed surgically and turned out to be a ectopic pituitary macroadenoma. The silent corticotroph adenomas, they have classical imaging appearance. On MR, they have microcystic appearance. That is around 90, has got the accuracy of more than 90% in differentiating corticotroph adenoma from rest of the adenomas. Here the tumor is showing microcyst plus macrocyst and shows heterogeneous enhancement. These tumors are more likely to present with hemorrhage. Here the tumor is showing bright area of bright signal intensity on T1 weighted images, show heterogeneous enhancement. There is a large cystic component which contain area of bleed on T1 weighted images. These are likely to remain. Residual tumor is very likely in such cases. This patient was operated and post-op we see the residual tumor. There is evidence of diffuse circular hemorrhage because of this tumor. For the evaluation of pituitary Cushing disease, we do inferior petrosal stepling, which is done by the Department of Radiodiagnosis. It evaluates the ACTH secreting pituitary adenomas in helpful in distinguishing central from peripheral source of ACTH. Here we, after admission, we do the place the sheath in both femoral veins and place the catheter into the internal jugular vein and place microcatheter in the inferior petrosal sinus and take the samples. The baseline samples are collected 3 minutes and 1 minute before stimulation, and after CRH stimulation, we again collect the sample from the peripheral sheath and from the microcatheter after 2, 5, 10, and 15 minutes. The example of petrosal venous sampling, we have seen that the two catheters are placed within the inferior petrosal sinus on the right side, and this is the left side in the jugular vein. We can see the evaluation of the both inferior petrosal veins. This is lateral view showing the inferior petrosal vein. The Cushing disease is confirmed when central to peripheral ACTH ratio is more than 2 at the baseline evaluation or more than 3 following CRH stimulation. Interpetrosal gradient of more 1.4 help in literalization of the Cushing disease, but it may be, one should be careful about the hypoplastic or anomalous drainage of the inferior petrosal vein when these values may be incorrect. Now I invite Dr. Amol for the surgical.
Thank you, sir. So once our endocrinology colleagues have confirmed the diagnosis and our neurology experts have helps us localize the tumor, then we proceed with the surgical management of these cases, and I'll be discussing the operative nuances. As any other surgical subspecialty, the cornerstone for a safe surgical outcome is understanding the understanding the anatomy. Like for this case of endonasal endoscopic surgeries, the understanding the anatomy of the middle turbinates, inferior turbinates, and the superior and its relationship to the quana and the sphenoid sinus is the essence for a safe surgical outcome. The use of the endoscopes gives us a brilliant illumination with a panoramic view right at the source of the lesion, and with this, the skull-based surgery has revolutionized over the past decade or so, and our department has also adopted this technique, and we can access the lesions as far as the cribriform plate in front and the anterior cranial fossa to the clavicle and the craniovertebral junctions at the back. However, the most of the functioning tumors present in the early part of the natural history of the disease because of the symptomatology that they cause, and our area of interest remains limited to the 4 blue lines, that is the two cavernous sinuses on both the sides and the anterior and the posterior intercavernous sinus to access the cellar area. And so the positioning for the endoscopic pituitary surgery, the head is flexed slightly in about 15 degrees. It is ipsilaterally rotated, and there is a contralateral tilt so that the surgeon is at a comfortable angle and can access both the nostrils for a binostril 4-in technique. And we use an abdominal fat incision or a thigh fat incision graft for preventing the postoperative CSF leak. Now let's look at the various stages of the surgical management. In these cases, the first step is the nasal stage, where essentially you create a space in the middle meatus between the middle and the inferior turbinates and the septum, so that you can access the quana, and about 1.5 centimeter above the angle of the quana lies the sphenoid ostium, and that can be either seen or palpated using a fine dissector. And also with using the modern gadgets like neuronavigation, it helps us to localize that. And once you localize the sphenoid ostium, you enter into the sphenoid sinus, widen that, do it bilaterally, and you proceed with the sphenoidal stage to disarticulate the posterior nasal septum, and that's a classical outside appearance which we see. And then you drill out the vomer and the keel of the vomer and the rostrum to enter into the sphenoid sinus. Another important aspect is that to understand the sphenoidal pneumatization, as there is a lot of variation amongst the patients depending upon the patient's age and the race. And there can be concave variety where the sphenoid sinus is completely non-pneumatized, the pre-cellar is partly pneumatized, and the incomplete cellar and the complete cellar are other variants. And the complete cellar type has further been subdivided into the subdorsal, occipital, and the dorsal plus occipital types. Another important aspect is the sphenoid septum variations, because many times the septum goes close to where the insertion of the optic nerve and the carotids are there. Hence, it's pivotal not to use a punch or a biopsy to take them out, rather than use a drill, either a cutting or a diamond drill, to proceed safely during the surgery. Now, next is the cellar stage, where we expose the cellar floor and the dura between the 4 blue lines in conventional most of the cases, that using a combination of a diamond drill and a small 1 millimeter or 2 millimeter kerosene punches, the dura is exposed, and then the dural incision is given in a semilunar fashion in the lower part, and about 5 and 7 o'clock, two separate incisions are given. And then the tumor dissection is started. First, we use the back curate, followed by the lateral sides, and then front. And at the end, we want to see this arachnoid bulge happening and a clear complete panoramic view of the cellar cavity. You can see that there is no significant tumor left. And this arachnoid bulge helps us to be sure about that. And a uniform bulge is the key to finding these cases. You can even look around the corners along the cavernous sinuses in these cases, so that where the tumors is invading the cavernous sinuses. A brief video to again elaborate on the operative nuances. This was another microadenoma case with Cushing's, and you can see that the size is about 10 millimeter or so in this patient. You again start with inspecting the nasal cavity, and you pass, and the endoscope is parked at 12 o'clock at the nasal aperture, and your instrument, whether it's a dissector or it's monopolar or a suction, is at 6 o'clock, so that there is no sword fighting of these instruments in a tight nasal corridor. You first identify the quana. There is a DNS, which is almost always a common finding in all the cases, either on the right side or the left side. Then you start with gradual lateralization of the middle turbinates. Sometimes the lateralization is prevented by a hypertrophic uncinate process and the bulla ethmodalis, and you can resect part of it so that the turbinates can be preserved and can be lateralized quite safely. Because the turbinates function has its own importance when it comes to moisturizing the air that we breathe and the nasal air circulation. And even the smell, the top part of it, is also relevant. Then you proceed with the monopolar cautery. You elevate a small, about 5 to 6 millimeter of posterior nasoseptal flap in all of the cases. And you can have a much more larger Haddad flap in cases where we do an extended endonasal surgery. However, in these conventional surgeries, it's not required. You identify the sphenoid ostium, as I've been shown here, and then you widen it to enter into the sphenoidal cavity. The same procedure steps are done on the left side, and once you adequately lateralize the sphenoid sinus, you enter into the sphenoid sinus on both the sides. You disarticulate the posterior nasal septum from the keel of the vomer, as you can see, and you can use either a drill or a punch or universal biopsy forceps to remove that. This is the classical outside appearance, which the image which I have shown earlier. And then you can use drill under continuous irrigation to enter into the cavity. This is the claval recess at the base, And this is a sellar floor. These are two paraclaval carotids, and you can see that in the microscopic surgeries we only able to see a limited area with a fixed retractor. The use of the endoscopy is to have a much more wider maneuverability and even drilling under very high resolution and magnification to ensure that the surgery is done in a much more safer manner. We use Garrison punches in the central part, and laterally for the drill can be done safely. And you can see that once the sellar floor is identified as the sellar dura is exposed, then the incision is given in the lower aspect with two cuts, one at the 7 o'clock on the shown on the right side, and the 5 o'clock incision is given. Then you dissect the tumor, the pseudocapsule, from the rest of the normal gland, especially relevant in the microadenomas, the Cushing's, and the acros. However, in macroadenomas, you can start with the intracapsular dissection as well. And then you use small punches, the 1 millimeter, the 2 millimeter endoscopic biopsy forceps, biopsy punches to take it. And you can use curettes, the down curette, the lateral curettes, and the front one. You go in the front at the last because the arachnoid bulge can prevent complete tumor removal otherwise. And there is always a brisk bleeding from the cavernous sinus that can be very well controlled with the use of gel foam and simple tamponade. You can see the cavernous sinuses on bilateral side, and there was no intraoperative leak in this case, and hence the fat wasn't inserted here. This is another case of Cushing's disease. I think it's the same patient. Sorry. This is a video of a 45-year-old female with a recurrent Cushing's, where, like Professor Ajay sir has shown that ectopic pituitary. This was an ACTH dependent ectopic pituitary, where ACTH dependent ectopic pituitary, where the gland was where the tumor was actually seen at the bottom of the right optic nerve, where it's getting close to the chiasm. And that's why we had to do an extended approach in this, where we had to drill off the part of the tuberculum cellae and the planum sonadale, plexus, the relevant part of the gland, and even the suprasellar area. And since this was a recurrent case, initially operated at CMC Bello, there was no nasoseptal flap that we could raise in this patient because it was completely scarred and there was septostomy. See that the tumor is being gradually harvested from the in the suprasellar area just below the chiasm, and the stalk can be seen very well preserved and the gland very well preserved. You can see the optic chiasm completely free of the tumor, and the patient went into remission. An interesting thing about these ectopic pituitaries that we've seen is that, unlike the classical, where the carcinoids and the squamous cell carcinoma of the lung, small cell carcinoma of the lung, etc., there's another case of ectopic Cushing's. Again, a similar case where the tumor was seen along the stalk. We have seen that even the low dose dexamethasone suppression test is adequate to suppress the cortisol production in these cases, unlike the carcinoids, where it requires a high dose dexamethasone suppression test. So it's basically somewhere a gray zone between the two diagnostic dilemmas, where whether it's really an ectopic or whether it's a eutopic pituitary adenoma. Again, an extended endonasal approach has been done, and this is the tuberculum cellae and the planum sonadale has been exposed. Use curved scissors to divide it in the center and then coagulate it gently using an endopin sometimes. And you can see the tumor is coming in front of you. It's away from the sellar cavity, and the recurrence was due to this. So again, the key important step is to have a good collaboration between the departments and to really diagnose it well, localize it well with our radiology colleagues, and then during the surgery, so that you can be sure that you have done the job completely and the patient can be cured for the remaining better part of their lives. And again, important thing is how to reconstruct the defect. You use a fascia to begin with, and then fat. And if you have an nasoseptal flap, that can act as a third layer, followed by a tissue glue just to hold it in place. And we use lumbar drain in most of our cases, such as these, to prevent a post-operative leak. Lastly, this is a transcranial approach was done for this case, which was a giant pituitary adenoma multi-compartmental. And again, the idea is to tailor the surgical approach as per the patient's requirement and do the justice for them. Thank you. Now I'd like to invite Professor MC Sharma sir for the continuing with the neuropathology.
Thank you. For a couple of minutes, I will speak on what are the changes in the understanding of pituitary adenoma classification. Since the Harvey described the pituitary adenoma and they were using only one stain, PAS, periodic acid shift, and based on the staining characters, they were calling it as chromophobe, chromophobe, acidophilic, basophilic. But later on in 2004, the classification was based on the 5-tier system, which was more of clinical, radiology, morphology, and immunohistochemistry. Unfortunately, at that time, and this was more prevalent ultrastructural examination, so they introduced the how to study the character of these neurosecretory granules and the individual cells, which is a very laborious exercise. And at that time, in 2004, they discarded these terms, acidophilic, basophilic, because it doesn't correspond to the functioning status of the. But they made it a ISC must for the various hormones and ultrastructural examination. And based on this classification, about 40 to 50% of the pituitary adenoma were non-functional, which is not true today. They are less than 5%. Now, the latest classification is based on the development of the pituitary glands. As we know that the anterior and posterior part of the pituitary gland, they develop from the different, this is from the Rathke's pouch, this is from the neurohypophysis from the central nervous system, and they develop under the influence of the various transcriptive, various factors, transcription factors, which are involved in the development of the different types of the cells. And these transcription factors, they can also be studied in the tumors which arise from those cells. For example, corticotroph, it is the T-pit for the LH and gonadotroph. This is the GATA3 and the SF1. And for these thyroprolactin and gonadotroph, this is the PIT1. So these transcription factors can be studied by immunohistochemistry. So the latest classification is based on the hormonal staining for the various hormones as well as these factors. And the other thing is, at that time, people were using the term, for example, the ACT secreting pituitary adenoma. In the latest classification, it is discarded. Now we call it as a corticotroph adenoma. So corticotroph adenoma is classified densely granulated, sparsely granulated, and Crook cell adenomas. And this classification is based on the number one is the hormonal staining, whether it diffusely stained or they're focally stained. And the second is the transcription factors. And the third is the cytokeratin positivity. This is the earlier cytokeratin positivity, pattern of cytokeratin positivity were not taken into consideration for the classification of the different pituitary adenomas have different patterns of staining. Sometimes it is very helpful. For example, in the somatotroph, this is the sparsely granulated. This is a, this is a dot-like positivity, paranuclear. So these patterns are important for the classification. For example, in the Crook cell adenoma, this is the ring-like positivity. This is taken into consideration for the classification of the pituitary adenoma. Now, the other terms which were introduced in the latest classification are the plurihormonal and double adenomas. Plurihormonals are one which same cell produce different types of the hormones. Whereas the double adenoma, there are two types of cells which are separate from each other. They produce two hormones. They are very less double adenomas, but plurihormonal adenomas, which were earlier people used to call as silent corticotroph type 3 adenomas, they are now classified as the plurihormonal pituitary adenoma. This is one example. For example, this is GH positive, FSH positive, ACTH positive, TSH positive. This is an example of the plurihormonal. This is a double adenoma. There are two areas. One is positive for ACTH and the TPIT, which is the transcription factors. The other area is positive for the prolactin and the PIT1. which is a transcription factor for the PRL. So this is the latest tumor, 4 months back operated, and it is a ACTH secreting functional. So pituitary adenoma now we classified into densely granulated, sparsely granulated, Brooks cell, and the silent one, which don't produce any symptoms, but they're positive for the hormones, type 1 and type 2. Now type 3, as I mentioned, they are now classified as the plurihormonal adenomas. Now today we know that every pituitary adenoma doesn't respond to the treatment. Surgery is the best choice. But many times there are examples where tumor recurs, the symptoms are not controlled. So it is very important to classify these pituitary adenoma. Some of the groups, they have the bad prognosis, whatever treatment you give. So it is important to identify all those groups. For example, ectotope macroadenoma in young, it's a bad prognostic. Silent corticotropic adenomas, it's a bad prognostic. And today we have some of the markers also which can predict which drug to be given if there is no surgical treatment. So these are some of these bad prognostic eosinophilic stem cell adenomas. For example, this is the PRL strongly positive, GH is locally positive. They have the mammals metatrope, they have the GH strongly positive, but PRL focally positive. So these are some of the examples which have bad prognosis. Now the somatostatin receptors are also predict the response to some of these drugs which can be given. For example, this SS3 somatostatin receptor 5 positive cells, they respond better and they have the more chances of the USP8 mutations. But in this case, it is the SST are 2 positive, so this patient may not respond to this treatment. So today we can predict the response to treatment and some of the tumor which the methylation status. For example, people are giving the temozolomide for some of those which are methylated, just like the most common mutations are described in the USP8 mutations, which are seen about 40 to 60% of the Cushing disease. It's a gain of function. This is the EGFR receptors, and it is destroyed in the lysosomes with the help of USP8. If it is mutated, this receptor is synthesized more, go to the surface and activate the ACTH synthesis and tumorigenesis. So these tumors, they occur in the female mostly. They are microadenomas and they respond better to the treatment, surgery, as well as the metastatin receptors analogs. But only 60% shows this. The next 40%, the 20% shows the USP48 mutations and 16% shows VRAF mutations. They are the activator of the different pathways. So today we have some of the drugs which can target these VRAF receptors. Some can target the USP, this NF-kappa pathway, and can decrease the symptoms. So this is very important to understand all these. This is one of the VRAF. We are doing some studies, but we are not very sure whether there is a focal positive or heterogeneous positivity and diffuse positivity. What is the significance with the actual mutation? So in the latest classification, atypical adenoma, which were based on the MIB labeling index, this term is obsolete. This is discarded. It has no meaning in the clinical practice. Now we use the term aggressive adenomas, which is more of clinical and some of the pathological features. This was called as adenoma at that time in 2014 because the MIB was more than 3%, but in 2017 it metastasized to the spinal cord. So some of the pituitary adenoma, they can metastasize. You cannot predict which exactly which tumor will metastasize. Prolactinoma and corticotropic adenoma are the sometimes more common when the levels, hormonal levels are more. So pituitary carcinoma is only used when there is metastasis. Atypical adenoma, as I mentioned, is replaced by the aggressive pituitary adenoma. The transcription-based classification is very robust, but only less than 5% are non-functional pituitary adenoma today. The hormone producing has been changed to TROF, and prognostic and predictive markers are better defined. Now, um, there is a lot of debate going on. I don't know in our country, but in America, people say that if you say the adenoma, it is not covered in the insurance because it is a benign condition. So surgery is not reimbursed. But that is one part. The second is, for example, the pituitary tumor, mean it is a benign tumor. So many are aggressive, many metastasize, many recurs. So that is why the people are using the term pituitary neuroendocrine tumor, just like the other tumors. And in the next classification, probably people are trying to classify it as just like the carcinoid, atypical carcinoid, and the neuroendocrine carcinoma into different grades. So pituitary neuroendocrine tumor is the better terminology. In future, I think that this will be replaced, adenoma will be replaced by the neuroendocrine tumor, and we can identify some of those which have the bad prognosis based on these immunohistochemistry transcription factors. Now, it seems that this classification is very based on the trophy, these transcription factors is very watertight, but I think this field is evolving. In this study, just to mention that they have studied some of the transcription factors, and they have found that some of those transcription factors they cross, they're not seen only in the one lineage of cells. And what people found that some of the gonadotroph receptor transcription factors, which are found in these growth hormone secreting adenomas and the ACTH secreting adenomas, actually they are all non-functional. So non-functional is very important rather than the transcription factor for the classification. And the non-functional pituitary adenoma have the worst prognosis. So any tumor which has for example, it has the GATA3 positivity, SF positivity, TP positivity, the acidophilic, corticotroph and the gonadotroph, they are likely to behave in an aggressive fashion. So the last, I will say that whatever you are sending, whatever surgery you are doing, whatever methodology you are using, you must send the whole specimen, whatever you find in it's the reputation of the surgeon as well as the pathologist is at stake. Many times in the private practice, especially, pathologists are forced to call it as a adenoma. This is a normal pituitary. We don't know whether it has gone to the brain or it is the second is our endocrinologists are they are so fond of hyperplasia. Many times they will force you to call it as a pituitary corticotroph hyperplasia, and after some time you will find that the adenoma is left. Thank you.
Good afternoon, everyone. Today, now I will be presenting the AIIMS experience, which has been a collaborative effort of many departments. So, this is the data of our department for last 10 years. Patients of Cushing's disease operated, around 160 patients were operated, of which 126 patients underwent primary surgery and 27 patients underwent redo surgery. And we analyzed these patients, removing the two patients who died and 11 were lost to follow-up. And remission was seen in 83 patients. And in 25 patients, there was persistence, and in 5 patients, was recurrence. And these were further subjected to either redo surgery, gamma knife, bilateral adenectomy, or medical management. So, checking the age distribution, the predominantly the patients in the primary Cushing disease group belong to the 20 to 30 years of age group, whereas in the redo Cushing groups, we had a higher proportion of patients in the pediatric age group, and we analyzed the proportion of sex distribution among the redo group and the primary group, and found that female population had a predominance in both the primary as well as the redo Cushing's disease group. And we checked for the clinical presentation and profile, and as has been added by the colleagues in endocrinology, that weight gain, skin striae, truncal tuberosity tend to be the common presentation in the overall as well as in the pediatric age group. We assessed for the presence of comorbidities as well in the adult as well as pediatric age group, and we found that hypertension was the predominant comorbidity, followed by diabetes and hypothyroidism. And we assessed the outcome of primary as well as redo surgery group, and we found that the remission rate based on the cost of cortisol in the primary surgery group was around 73.5%, and in the redo surgery group was 57.2%. Though the remission rate was higher in the primary surgery group, the on statistical tests it was didn't come out to be significant, but there is definitely advantage in primary surgery with a higher remission rate of around 75%. And then this is the single surgeon data of Professor R.C. Suri, and with similar, with equally good results in primary surgery group around 75% and redo surgery of 66.7%. And we assess the role of preoperative biochemical markers, including preoperative cortisol, preoperative ACTH, overnight external suppression test, low dose suppression test, and high dose suppression test. And we assessed for among the various groups who underwent remission or persistence or recurrence in the long term. And we did not find any significant correlation between these preoperative factors affecting the outcome in the overall group. Similarly, for the redo surgery group, we subjected the analysis for the preoperative cortisol, ACTH, ONDSC, and HTSC, and we did not find any significant correlation in predicting remission or persistence for these preoperative biochemical markers. However, the post-op cortisol was found to be a significant predictor of the outcome, with patients in the remission group having a median of about 2.4 for microgram per deciliter, whereas those in persistence around 23 and recurrence group around 15. So based on this data, we tried to analyze the receiver operator curve analysis, and we found that the area of post-operative cortisol predicting remission was around 90% accurate with a cutoff 11.2 with a sensitivity of around 85% and specificity of around 92%. Similarly, postoperative cortisol was found to be a significant predictor of remission in the pediatric age group as well. As well as in the redo surgery group, we found that again the post-op cortisol was found to be a significant predictor. So this is very important factor that preoperative parameters biochemical did not turn out to predict it is the post-operative parameter which predicts the outcome, especially the cortisol in the primary redo as well as in the pediatric age group. Similarly, postoperative ACTH was found to be a significant predictor of outcome in the overall group, the primary group, in the pediatric group. However, it did not come to be significant predictor, though the patients who underwent remission in the redo group also had a lower ACTH level, but this did not come out to be significant predictor of the remission outcome. Also, we found that the patients who are belonging to the pediatric age group, they tend to have a poor outcome as compared to the adult age group. So nearly half of the around 36.8% remission rate in pediatric population and almost twice in the adult population. Another factor which we found that the remission rate in microadenoma was around 70%, whereas those with macroadenoma were around 86.5%. So this could be attributable primarily because of a small number of proportion in the macroadenoma group. And another thing which could be that macroadenoma are much more easily visualized on preoperative radiology, so they might be easier to remove them. We compared the surgical approaches as well, and we found that the endoscopic approach tends to have a much better outcome and has much more higher remission rate as compared to the microscopic surgery, with endoscopic surgery having a remission rate of around 83.5% and microscopy having a remission rate of around 65%. We subjected the histopathological data which was provided by the Department of Neuropathology of 121 patients, of which 92 patients reported a positive biopsy with ACTH adenoma. 27 patients had other biopsies including normal pituitary, blood clot. One patient had corticotroph hyperplasia and one patient had GH adenoma. So one important finding which came out to be that if the histopathology reported a positive adenoma, it was likely to have a higher remission rate as compared to those patients who did not have a positive biopsy. The remission rate in patients with a positive histopathology was around 80%, whereas those without a positive histology tend to be around 50%. We assessed the analysis for the novel markers and generation pattern also for somatostatin receptor 2 and 5 in around 30 patients, probably because of the low number
of patients in individual groups of persistence and recurrence, we did not find any significant trend, and maybe in future with prospective data, we'll be able to confirm the role of these novel markers in predicting remission in Cushing's disease. Also, we assessed for the complications in the overall pediatric age group. The mortality remains, the surgical mortality remains low, and only 2 patients had a death in the overall group, with none of the patients in the pediatric age group. The electrolyte imbalance and postoperative diabetes insipidus remains the most common complications post surgery. Now, surgery remains the treatment of choice for Cushing's disease. Now, where comes the role of gamma knife radiosurgery? Gamma knife radiosurgery is indicated for those patients which have surgical failure. Generally, 2 to 3 surgeries, we give a patient a chance, and even if despite those, we are unable to treat the patient and the patient has this biochemical recurrence, then such patients can be subjected to gamma knife radiosurgery, or in cases where patient is unwilling for a repeat surgery. Primary gamma knife is not indicated. We generally give a gamma knife radiosurgery in the dose of around 25 gray. Earlier used to be higher radiation, but that does not has proven to have any benefit. So we're giving 25 gray radiation. In our experience, we have given gamma knife to around 30 patients, in which 21 patients received gamma knife once and remaining 9 received twice. And follow-up was available for 11 patients, which showed that the remission rate was around only 20%. So this is an important message that even gamma knife is indicated for only redo surgery with recurrent surgical failure, and the remission rate with gamma knife is around 20% only, and should be given only in cases where the patient either is unwilling or when the surgery has failed multiple times. We are giving a chance of up to 3 surgeries in our department. So now I'd like to invite Dr. Shantanu to discuss the review of literature.
Thank you, Ravi. Literature is abundant with publications regarding the management of Cushing's disease. It is because the Cushing's disease is actually a very difficult disease to treat. The systemic reviews and the meta-analysis helps us to have an overview about the Cushing's disease. This meta-analysis published in 2015 shows that even after successful biochemical or surgical remission in Cushing's disease, the mortality remains high. This brings the importance of a multidisciplinary approach in this disease. As soon as the patient comes to us, there should be no delay in diagnosis and management so that we can give the benefit of this multidisciplinary approach to the patient. This is our latest publication from our department regarding the management of Cushing's disease. This is a very important publication because it has changed the trend in the shows that endoscopic surgery is significantly gives better remission rate than microscopic surgery. It is already mentioned that it is because it gives a panoramic view of the cellar and the paracellar region, including the cavernous sinus. So excision is better and it gives a very good outcome. So this is a literature which shows that the importance of preoperative neuroradiology. If we can diagnose, if we can localize the tumor preoperatively in MRI, then the success of remission increases up to 82%, but if it is not diagnosed, then it is 50%. So this is very important, but whatever is the MRI result, we should always go for surgery because this is the primary mode of therapy. So this is a meta-analysis published in 2018, which shows that emphasize our findings that endoscopic surgery gives a better result for remission than microscopic surgery. Now, I have already mentioned that Cushing disease is a very difficult disease to treat. So there is lots of cases of persistence and recurrence. But even in those cases, the main option for these recurrent cases are the surgery, though the results are not as better as the primary. It is almost 50 to 60%, whether in case of primary surgery, we get a result of almost 75 to 80%. Radiosurgery, as Ravi has just told, the results are not better. It is usually never used for primary management. It is used after multiple failures in surgery, and then we can give the gamma knife, and the results are not much better than 20 to 30% in our experience also. So there are lots of studies are published in the literature about to find what are the factors that affect the outcome. The main important factors which are found to be is the microadenoma. The microadenoma gives a better result, And if the ACTH positivity is there, it gives a better result. If MRI positivity is found earlier preoperatively, then it gives a better result. And endoscopic surgery gives a much good predictor than microscopic surgery. So this is a meta-analysis which summarizes the findings that transsphenoidal surgery is the most effective in primary microadenomas, which is visible on preoperative imaging and without the cavernous sinus invasion. And if the lower preoperative 24-hour cortisol, and if the post-operative first day morning cortisol is less than 2 microgram per deciliter. So these are the factors which predicts a good outcome. So in a conclusion, this is a very smoldering disease, means it is very difficult to treat. So it needs multidisciplinary effort. Transsphenoidal surgery remains the treatment of choice for Cushing's disease, which gives 75% remission rate. In recurrent disease also, surgery remains the gold standard, but it gives approximately 60% remission rate. Out of endoscopic and microscopic, endoscopic approach has a definitely better remission rate. So now the trend is changed from microscopic to endoscopic surgeries in our department also. And the other factors which favor long-term remission are the adult patients, then the post-operative day 1 cortisol in ACTH level, and positive histopathology. If histopathology is found to be positive, then the remission is also seen to be better. And gamma knife is recommended only after recurrent failures of surgical management. Now I request uh, Farid.
I would now like to request Professor Kale, the head of our department, to give his closing remarks.
Good afternoon, everybody. I think this was a comprehensive presentation. Classic example of a pathology which needs a multidisciplinary approach. Classic example. You need surgeons, you need physicians, you need radiologists, you need radiosurgeons, you need radiation therapy, you need everybody. Even then, your remission rate is, or the control rate is about 75-80%. Any questions?
No, I think in teaching institutions, you can one should send, because for example, if you have the tumor and the glutaraldehyde, you can process for EM. If it is not needed, you can process for the routine. But for example, if something is rare where you want to do electron microscopy, you cannot take a sample again. For now, for the microadenoma, it may not be very helpful because we don't. But for the macroadenoma, which turned out to be something else, that's in a teaching hospital. I think one should take no problem.